Our next topic is another very important topic on virtually everyone's agenda as we try to move forward and address many of the components of what is often referred to as quality, value-based purchasing, value-based formulas of care, as well as the safety components, and that is care transitions and how we can most effectively achieve the results that I think everyone is striving for, but yet are complicated by the various components that go into the whole aspect of the subject and the fact that there are so many players. It's kind of like an orchestra where you're trying to direct a tuba section and a saxophone section, but yet at the end of the day we all want it to make good music and have a good result. So care transitions kind of fits in that for me as a visible component. So kind of moving, the topic today is moving beyond blame to fill the patient's needs, and that's the perspective that we're going to be trying to come at with today. We have a nice panel of presentations for you. Again, as you can see, we're continuing the thrust, if you will, of making sure that we have not only the practical experiences, the real-time observations, as well as the expertise added to our panel, and this will be just like that. Our panelists today are Jackie Conrad, Kathy Munn, Kelly Benson, and Kathy Hodge. I'm going to go through a little bit of information relative to this. The sequencing as they will come forward, I hope I have that somewhat scripted here, but if I mess up, y'all just please cover whatever I've messed up on. But our first speaker will be Jackie Conrad. She's an improvement advisor with Sinusure Health and has more than 25 years of hospital leadership experience serving in clinical, staff development, and executive roles. Background is in rehabilitative nursing, and she has served 2 organizations as the chief nursing officer in a large urban teaching hospital and a smaller community hospital. So has a very nice perspective. I guess you would say represents kind of the Alabama market, if you will, in terms of facilities, in terms of size. Following her will be Kathy Munn. She is the Advanced Quality Improvement Lead at AQUAP. She's been in the healthcare field for 35 years and is currently focused on developing and sustaining community coalitions. Kathy will provide a brief overview of AQUAP's work, the regional care transition programs, and then turn the podium over to Kelly to share, along with Kathy, some of the successes from the Montgomery region that are being experienced as a part of the care transitions program. Kelly Benson is the Director of Community Care Management for Baptist Health in Montgomery, and she's worked with the system for more than 10 years, overseeing a variety of service lines, including patient accommodations, care coordination, cardiovascular ICU, and cardiovascular step-down unit. She'll be joined also by Kathy Hodge, who is the Quality Director and Risk Manager at Medical Center Barber in Eufaula. She has served as a number of positions at the hospital, including nursing, data analysis, and utilization review. She has specialized training in a number of areas, including wound care, infection control, and geri psych. So it's my pleasure to introduce our panel and the expertise that they will bring from their various perspectives here, and ask Jackie if she would take the podium.
Great.
Okay, thank you, Jackie.
Thank you so much. It's a pleasure to be here. So I'm hearing lots of themes that really reinforce what we're going to talk about up here today. So I heard, look at the big picture, and we need to look at the entire clinical picture of the patient. I also learned that if we do what's best for the patient, it's also going to help the hospital and the practitioner. So focusing on the patient. We want to make it easier for the end user. I heard that quite often, and the need to celebrate. So before I get started, I just wanted to share a little bit about the work that I do. I work with Sinusure Health, and we're subcontractors with the American Hospital Association, HRET-HIN. And we are 1,600 hospitals strong, and we're working on reducing harms and readmissions across the country. So I come to you today with a very high-level overview about what we see happening in hospitals, how readmissions care and improvement is evolving across the country. So I want to share some best practices and how we're shifting from looking at providing services based on eligibility to look at services based on need, and to focus on what the patient needs. And when we focus on what the patient needs, the hospital excels, and so do the providers. So really, really excited to be here. So why don't I go ahead and jump in. My first slide is, it kind of depicts why we're here and why we need to look at need-based care. So here's a quote from a patient who was readmitted, and he said, when he asked why he was readmitted, he said, "I ran out of Lasix." Lasix costs $4 a month at Walmart. So what is wrong with this picture? If we have a patient, and this may be a patient that comes back to the emergency room often when he runs out of Lasix, we need to fix these basic problems, and that's what we're going to talk about today. So I'll give you a 25-minute overview, and then we'll really get into the meat and bones of care coordination out in the community. And I'm not going to talk about what you need to be doing in your hospitals, the basics of hospital-based services like discharge phone calls, having an appointment in hand when the patient leaves, because we've moved beyond that. That was Readmissions 101. We're moving into the next phase, and that's really breaking down the walls and getting out into the community to serve our patients better. Agree? Okay. I don't like to be the only one talking, so but I will put up with it because we've got a lot to cover. So when I think about this work and the themes that I've heard, I want to share with you a theme that CMS, who sponsors our HRET HIN, and many of you are probably engaged in the HIN, but we're working on reducing harm and readmissions. And another scope that CMS wants us to integrate into our work is we want to reduce burden and bring joy to our work. And I think that that's possible. And I kind of say it tongue-in-cheek, and it's like I try to be sarcastic about it, but really, I believe that if we start working smarter and we start having a data-driven approach and we get involved in team-based care and we really serve our patients well, we can reduce burden and we can bring joy to our work, because it feels really good when you do what's right for your patient rather than bucking the system and saying you're not eligible for these services. So I don't want you to continue to operate like this, because this will not relieve burden and it will not bring joy to your work. So what is the definition of insanity is doing the same thing and expecting new results. And we know that working harder is not the answer. So we've really got to think about a new way of addressing our readmission problems and opportunities. So what would be better? And I propose to you that a better approach would be to be data-driven and to have an approach that's informed by your data. Not just the big data. We're going to talk big data. I'm just going to spend a few minutes on big data and little data, and I'm going to share with you some tools that our HRET HIN have deployed, and we're gathering a lot more information, and I'll share with you some of the trends of what we're seeing when we're looking at both the big data and the little data. So when I think about big data, we're looking at your entire readmissions population. We're looking at your race, ethnicity, and language preference data. So we're looking at your DRGs, your discharge diagnoses, and this will help us to target what groups we're going to approach. And it's really thinking beyond the DRGs. It's looking at diagnoses and discharge disposition. So we're looking at really a lot of data. And when we look at the little data, that's really when we're looking at our day-to-day operations. So these are the conversations that we have with our physicians and our patients about what the problems are and where our gaps are. And this too, the little data can help us to fine-tune our approach with the big data. So why use the big data? Well, we don't want to end up in the penalty box. We want to spend our time proactively addressing patient need rather than responding to penalties. And we really want to look beyond the DRGs and look at discharge diagnosis, because if we only look at our top DRGs like our COPDs and our acute MIs, we're going to miss the boat. There's a lot more patients that are being readmitted into your organizations. So drilling down on the big data, when you download these slides, you'll have access to this link, or you can go on the HRET HIN website. And this is a very robust multi-tab spreadsheet where you can enter data. It's going to take you a couple of hours, but you would be really wise to make friends with a data analyst that will help you to pull this information together so that you can make an informed decision about how you want to take your readmissions work to the next level. And one of the themes that I see happening in our HIN work as we are trying to reduce burden and bring joy to our work is sometimes we have to segment our work and we can't address our entire patient population. So identifying a smaller segment, a targeted population, it can make some of this work more manageable. And by doing this big data drill down, it can help you to get that information. So it'll tell you your readmissions by payer, your top discharge diagnosis. We really want to drill down on behavioral health. We've been turning our head to behavioral health issues and saying we don't have the services to provide for these patients. Well, hospitals are beginning to look beyond their four walls and they're providing these services, and I'll share with you some strategies. We want to look at days between discharge and readmit because that can give us some insight into where we want to intervene, and discharge disposition by payer, and then starting to look at our high utilizers. And a high utilizer would be a patient who has been admitted 4 times or more in a calendar year. And what can we do to help that particular patient and provide patient-centered care? How can we rally around that patient? So this is an example of some of the big data, and this is discharge destination by payer source, and what we can glean from this graph is that Medicare has the highest discharge to skilled nursing facilities and the highest discharge to home care. And then our Medicaid, uninsured, and commercial patients are all pretty stable in their utilization of these services after discharge. I just wanted to put this up here to ask you what you would prioritize. When you look at this data set, and just at first glance, where would you want to target your efforts? Would it be the patient population with the highest rate? Look at your heart failure and your renal failure are at the 22% and 20% readmission rates. But when I look at your septic data, your septic patient data, they may have a lower readmission rate, but they've got a higher volume. So you don't necessarily just want to go with your highest rate. Go where you've got the highest volume, and that is going to help you serve more patients and touch more lives in a positive way. So the little data gives us another perspective. It helps us to understand from the patient and the provider perspective where the gaps are, and to really understand the reasons why patients are being readmitted. And it can help us to develop a better plan for specific patients. And it really helps us to look at our plans over time and prioritize repeat issues. So it's really getting down and understanding from the patient's perspective why they were admitted to the hospital. And we keep asking why and trying to uncover the why. So another tool that is available to you is the Aspire 2 tool, and it's a readmission interview tool. And so some of the information that I share with you today is gleaned from a challenge that we made with our HRET HIN hospitals to interview 5 readmitted patients when they come back into your facility and start to understand what the drivers were for their readmission. This is an example of the interview tool questions. It's very simple. I've seen some advanced organizations start to use their patient family advisors to interview patients because patients are a little more transparent when they're talking to a peer than to a clinician. They only take 5 to 10 minutes, but we really want to get from the patient's perspective what their feelings are about what brought them back to the hospital and how things unfolded when they got home, when they started to not feel better or feel as good, and what prompted them to come back to the hospital. So after you do these interviews, we can start to aggregate the data and start to see trends. And what we have here is some sample data from a hospital, and they did it looks like about 20 readmission interviews, and they found that palliative care issues, which were absent in their community, were driving a lot of the decisions to be readmitted, as well as medication issues. So that combined with the big data was telling them they had issues with septic patients. So we're going to focus on sepsis, and then palliative care and medication management were other opportunities at this organization. So let's jump into that need-based care. So in the HRET-HIN change package, we have different key drivers, and this I'm going to drill down on this key driver, and that is providing enhanced services based upon need. And we'll work through palliative care services, chronic care, and work through those different topics. But I think it's important to realize that when we're going to provide advanced services or enhanced services, it's going to cost money. So we want to make a good decision about where we will prioritize to fill these gaps. And think about it. $4 for a prescription of Lasix, and that's really not the answer. It's not paying for the prescriptions. There's plenty of services out there that are bringing meds to bed before that patient is discharged, and I'll mention those in just a few minutes. Okay. So the areas that we're going to drill down on are enhanced services for palliative care and advanced care planning services, patients diagnosed with sepsis, some of the things we're learning around there, behavioral health services, medication-related problems. It even has an abbreviation, MRPs, medication-related problems, and high utilizers. And then I'm going to touch on the ED pause as well. Okay, so palliative care, how many organizations or communities have gaps in palliative care? I know that this is a problem in our rural settings where palliative care services may not be available. Anybody have gaps in this area? I see heads nodding. So there's a lot of things that we can do to support palliative care services like PULSE, advanced directives, the Conversation Project. There's lots of things out there. But I want to cue you in on something that I think is very viable, and it can help you to bring in reimbursement and provide exceptional services, and that's advanced care planning. And when we look at the definition of advanced care planning, it's that face-to-face interaction by the physician or another qualified healthcare provider. So this is really all about team-based care. And when you place an advanced care planning nurse in a primary care setting with a physician, these are billable charges. And when you're talking advanced care planning, we're not talking about creating an advanced directive. That may be an outcome of advanced care planning, but it doesn't have to be. So every time we have a conversation with a patient about their complex care and their care needs to keep them outside of the hospital, those are billable services with CPT codes of $82 to $72 for a 30-minute session with a nurse. And think about having those conversations out in the community before the patient is really taking a turn for the worse and the family's not sure how to handle this situation. They're going to return back to the hospital. But if we can have these conversations early on with our patients that have very complex needs, we can curtail some of these visits to our emergency rooms, which are ending up as readmissions. Anybody have advanced care planning services in your organization? Raise your hand so that we can see anybody. Okay, I'm seeing this really taking off in our rural communities, so we're seeing a lot of uptake there. Now, what we're seeing with sepsis, when we're drilling down on our sepsis cases, is that we're finding that these patients are returning back to the hospital in 7 to 10 days. And so what we're seeing as a strategy around that is to have an early provider visit with that patient within the first 3 to 7 days after discharge. And that has been a strategy that, based on talking with patients and understanding what their needs are, getting them to their primary care physician early is a key strategy that we're seeing work with our sepsis patients. Because they do leave the hospital with that post-hospital syndrome, and they're very weak and very vulnerable. They really need to, that would be a priority patient population that I would suggest you take a look at and see what you can do to really meet the needs of these very complicated patients. And then our behavioral health patients. I'd be curious to see when you drill down how many of your patients that are readmitted have a comorbidity of a behavioral health diagnosis. And you can use the ICD-10 codes, the F0 through F9, to do that search to see how many comorbidities there are. Because if you have a high readmission rate around this, you may want to start providing services even if they're lacking in the community. Now, some great things that we're seeing happening out in hospitals is to have high intensity services, to have clinics for patients with behavioral health needs, and that certainly is a high intensity service. But I'm seeing some softer methods being used in hospitals, and they're populating their care transition teams with mental health workers and people with behavioral health experience, so that they're more cued into the behavioral health issues of the patients and hooking them up with resources out in the community. And organizations are developing these services out in the community. I just met a hospital out in Casper, Wyoming, and they have one patient who is a diabetic who goes into ketoacidosis, and he's being readmitted every week with his problem. But it's not that he is mismanaging his diabetes, it's because of all the psychosocial issues. And once they started addressing his psychosocial issues and his anxiety and really started listening to him, and he was having frequent visits now. He started to have frequent visits with his primary care provider where they're checking his blood sugars and supporting him. He was really longing for social interaction. And it's a victory to this team when he hasn't been back in 2 weeks. But they are making this patient a priority, and they're starting to see improvements, and it's bringing joy to this team in serving this patient well, because they know if he continues, he will not survive. And this is a young man, he's in his 30s, and he's just not coping well with his diabetes. Home-based healthcare, home-based services, I'm seeing home care services provided by hospitals that don't have home care services. They're sending their own nurses out to visit the patients to fill those gaps. And then certainly reaching out to clergy and other community organizations. Medication services, there's medication services for your behavioral health patients. They can provide meds to bed and do all the billing for your patients and all of their paperwork. So there are services out there that are evolving and popping up. So a little bit about MRPs, the medication-related problems. So 1 out of 3 readmissions have some sort of a medication-related problem. So having a patient leave with just a prescription it's probably a crapshoot that they're really going to get that filled before they get home. So having those meds to bed is really has been evolving, and it's kind of it's really spreading across the country. And think about how comforting that is for the patient, that they have what they need when they leave and they don't have to make a separate trip to the pharmacy. What I'm seeing happening is that the hospitals are using their outpatient pharmacies to provide these services. And if you don't have an outpatient pharmacy, you can contract with your local retail pharmacy within your community. And then there are also mail order services that can provide these services for your patients as well. And they complete all the paperwork and the pre-authorizations for the patients. And they do refills as well. Our high utilizers, I think that this is a great application for your advanced care planning. If you go down that route, advanced care planning is not a high hurdle to overcome. Nurses can easily become trained. There isn't a required certification. They have to understand the role, but they don't have to receive a certain designation to be able to achieve, to be able to bill for those services. So think about if we could have someone really working with a patient with complex needs who's a frequent readmitter. Can we help to streamline their care and provide better services and keep them out of the hospital? And really think about what that patient needs. we're seeing a movement. I'm from the Chicagoland area, and we're seeing a movement where if they've got a frequent flyer who keeps coming back to their hospital, I saw a hospital actually address a homeless issue, and they got the patient an apartment. So now, instead of him coming to the emergency room for care and for socialization, now he just comes for socialization to see the nurses and to say hi, but he's not coming to be readmitted in the hospital because they looked at what that patient needs. And so I want to challenge you to think about your high utilizers. It may be hard, it may seem to be hard, but if you can keep that patient from continuing to return to your hospital over and over again, you're going to be doing that patient and your organization and your staff a huge favor. So my final strategy is I just wanted to shine a light on your emergency rooms. We're seeing the implementation of an ED timeout as one of the strategies that we can use that's very focused. Because when we're looking at, this was a large study, a JAMA study looking at readmissions, and they found that about 26 or 27% of readmissions are avoidable, and the emergency room decision to admit the patient is one of the leading contributors. It's kind of like a reflex. I mean, we're balancing our throughput, right? So we're trying to balance the throughput and get the patient through the emergency room and placed into a bed if we think that that's where they're going. But we want to stop that reflexive, get them through the ER, and let's make sure that we place them in the right status and that they require medical necessity to be readmitted. And if we can manage them as an observation patient to protect us from the readmission, let's take a look at that. Anybody using that strategy in your ER? Are you populating your ER? So do you have a case manager in your ER? Okay. Anyone else having a case manager to deal with these? And is that helping with your readmissions, to have someone that's dedicated to do that? We've got a head nodding here, and how about you? Has that been helpful to have a case manager? Has that been deflecting some of the readmissions?
We've avoided admissions going back to the nursing home,
Okay.
antibiotics, as well as making them an inpatient versus hospital.
Okay. So it's working. Okay, it's working with your heart failure patients, and it's also preventing patients to be readmitted back to long-term care with IV antibiotics, you said? Okay, excellent. Great. Okay, so the ED pause will disrupt that ordinary process of that automatic readmission, and it's really important to know who was recently readmitted. So some of our organizations put a flag in the EHR, but that's only going to capture if that patient was readmitted from your facility, but that can flag so that we can really take a look at that patient and what their unmet needs are and how we could handle those without causing a readmission that is avoidable. Okay. So with that, I'm going to pause with my ED pause, and I'd like to introduce our next speaker. So I'd like to introduce Kathy Mumm, and she's going to share with you from another big picture perspective on some care transitions work that's being done. Okay, thank you very much.
Very good. 20 seconds to go.
Kathy, would you like to use the laptop?
No, I'm gonna. Okay.
See if that one works better.
That one does. Perfect. So I too have 5 minutes, and many of you in this room, I know from the work that we're doing in the communities with AQOF, and so I want to spend just a couple of minutes talking about what is a QIN and a QIO, and then what we're doing across the state. You heard Dr. Smith say earlier that we have kind of changed. Years ago, each state had a QIO. AQOF was one of those. We are now part of a larger, one of the 14 QINs across the state, and so we're part of the ADAM Alliance, but that hasn't changed what we're here for. We are working to bring those Medicare beneficiaries, our providers, and our communities together for that ultimate goal that we all in this room share, and that is to improve clinical outcomes and patient safety and satisfaction. We want healthier communities. We want better transitions of care. I don't think there's anyone in this room that would disagree with that. And so one of our strategies across the state is the 7 communities that you see here. We go from Florence with the REACT community all the way to the Gulf Coast with the Healthy Gulf Coast, and then not all ports in between, but a vast majority, about 65% of our Medicare beneficiaries are covered across the state. We're very fortunate this morning to have Kelly Benson from the Impact River region down in Montgomery, who's going to share some phenomenal work that they're doing to impact that care transition and the lives of their congestive heart failure patients. So we're real excited about the work that's going on there. We have lots of good initiatives that are going on across the state. You heard about advanced care planning just a moment ago, and that's something that we have going on in all of our communities across the state, as well as initiatives that involve parish nurses and bringing that faith community into the care of the patient as well. We have the model here from the IHI, the triple aim. And when I first read the 4th aim of bringing joy to the workplace, it made me rather stop and chuckle because you don't really think about that. But we have to have that joy. We have to be happy in what we're doing, or we're not going to have the results that we need, because we become calloused, we become mundane, and people don't take us seriously. So I think the addition of that 4th tenet of our aims is probably very well needed. It's going to take us a while, I think, to get to that joyful part, especially as we think about changing regs, as we think about the Joint Commission, as we think about more needs of our patient and less money to do those things. So it will take us a little bit to get there, but I think that everyone in this room has that joy, or we wouldn't be doing what we do. We are now in the final phase of the 11th scope of work. These are just some of the goals that we have before us, and if you're part of one of our communities, you know that we are working to reduce readmission rates by 20% by the end of our contract, which is July 31st of 2019. I will tell you, despite our best efforts across the country, we believe that while we'll come close, we're not sure that we will make that goal, but we are not going to quit trying. We believe in the 12th scope of work, and this is certainly not the opinion of AQOF. It is not the opinion of CMS, because we don't have anything finalized yet. But we believe that the work in the communities will continue. The work around the transitions of care will continue. Chronic care management, reduction of burden, opioid utilization will continue. So with a lot of the things that you see here and that you see us doing in the communities, we believe will continue in that 12th scope of work, which will start August 1st of 2019. A little bit sooner than ICD-11, I might add, which in all ways, shapes, and forms will probably be 2025 by the time it is vetted, and I too will be retired by then. So with that, I'm going to turn it over to Kelly Benson, who's going to share some of the work that they're doing down in the Montgomery community. And Margaret, I'll let you do that. Here's Kelly.
Okay, so I'm really short. Glad I wore my heels today. When I seen the podium, I was like, oh, I'm going to have to tiptoe or either take the mic down, one or the other. Okay, can you hear me? I'm a little loud. So, all right, so I'm Kelly Benson, Baptist Health from Montgomery. We have a large group with us here today, so yay, go team. We have done a lot of exciting work for heart failure, and I think that my presentation is actually a really good segue in to what Jackie talked about, because that's exactly what we did. It was actually through the help of AQOF as well. So we put the community together, and they started bringing us this data. So what we did was we took the big data, and we wanted to see what population we needed to focus on. We knew we needed to start with someone that had high volume, not looking at the rates, but how can we change those lives? And then we actually started pulling down the smaller data through our quality department, which that's us at the front table here. So we started pulling all of that down to see exactly what are some of the specific things that our organization as a whole needs to work on. So I'm going to go through some of those today. All right, so some of the things we're going to be doing is looking at leveraging. We all have a limited amount of resource, and so you wanted to work with what you had available to you, but at the same time start to make those transitions to where you can keep the patient safe. You wanted to make sure that we're going to describe some key interventions. I'm not claiming that we came up with every one of these. I will say that part of what we have found within the communities through AQUAF is we have shared a lot of things back and forth. Not only things that have worked, things that have not worked. It has worked really well, and I think that's one of the biggest things that AQUAF has been able to provide us. And then at the end, we want to review some of our impact. Are we doing making change for the sake of change, or have we seen results? So we'll go over that as well. So the first thing that we wanted to make sure is that we knew everybody knew who was high risk in our organization. So at one point, this was like the best kept secret for case management and care transitions. We were the only one who knew that. We use a predictive analytics software called Javion. We love it. They're actually predicting at about 71% right now of patients before they are discharged. So before this, we were using the modified LACE tool. We were not getting the results that we needed, so we started digging into this. Javion's actually not excited about that number. They think they can do better, but we were excited to be able to say, hey, we're pinpointing these patients before they leave the hospital. And we also need to share that with someone other than a case manager or a care transition manager. So what we decided to do was we needed to make sure that during the multidisciplinary round, someone was challenged to be able to let that physician or that practitioner know exactly who was considered high risk. So we put a process in place that now during the rounds, they make sure that not only is do they know who is high risk, but that we're also offering some post-acute services if necessary for those patients. So that kind of leads us into this. We looked at our data, which is what AQUAF provided us, and we wanted to see, okay, so if we are taking these high-risk patients, and this is based off of heart failure, that was the initiative that we chose, how are our home health companies doing? How are our SNFs doing? If they're going home, are they coming back? So here's what we found. 50% of our patients that were going home were coming back. Our skilled nursing and home health within our area, we have about 45 skilled nursing facilities and about 15 home healths. They are actually, their rates are below average. They're below benchmark, so they're doing great with their readmissions. They're helping us. It's new for skilled nursing facilities, which are now being penalized with readmissions. They're jumping on board, so it's not just a hospital's fight anymore. They're trying to make sure that these patients have a better outcome. So we engaged both our home health and skilled nursing facilities, and we thought, okay, problem solved. We're gonna say it in rounds. We're gonna say, hey doc, this patient is high risk. We need to make sure that if it's appropriate, let's do home health or skilled nursing. Problem solved, right? What did we find? At this point, the patients started saying, no, we really don't want to do home health. They were really what we found, and that was through some of our readmission interviews, was that the patients were afraid of that independence. So they seen home health that first time as you're going to come in, you're going to bathe me, or I don't need help with dressing, I kind of don't need this service. So we didn't do a good job as case managers trying to explain to them, what the services were for. So we actually changed that scripting, and we released that out to the case managers a couple of months ago. It seems to be working much better. So at that point now they're saying, we want to help you take care of yourself. We want to make sure that we are there to support you through this time, that post-discharge scenario that we talked about where they're still weak and they need help. But then we also want to be sure that we just get you over that hump, and once you're better, then that independence returns. Once we started using that scripting, things has gotten a lot better, and our home health referrals have actually increased. So real-time readmission notification. We wanted to be proactive, with our action plan and try to address readmissions, but we also needed to understand real-time when you had a patient that was being readmitted back into your hospital right then and there that the patient was there. So everyone was asking, well, why is that something we need to look at? I even had a physician that wanted to take it to one of our teams, and he said, talk me through this. Why should I add this into your EMR? And I said, okay, so it's not a red flag. It's not, oh, I don't want to admit this patient. Where did we fail the first time? Was there something that we could have done better that first discharge that we need to make sure we don't make this same mistake again? So, some of the things that I was telling him, is that clinical condition worsening? Is it time to have that end-of-life conversation? Are there social services that are available within the community that we're not tapping into for this patient yet? Have they, at this point, can they return to their prior living situation? So there were several things that we wanted to. We actually put this in the case managers and the discharge planners were able to see this first, but just 3 months ago, we rolled this out to physicians, and we have gotten a lot of positive feedback since then. Missed opportunities for hospice. So when nobody else raised their hand, I would not raise my hand because I was behind the table. But we actually have the same thing. So we have a 3-facility system. We have palliative care in our mothership system, in the large one. We do not have palliative care within the other 2. So what we found when we were doing a lot of our deep dives is that we were embarking in palliative care conversations in the facilities that had that, but our other 2 standalone facilities were not really, embarking in those conversations. And so, of course, we took it back to the hospitalists, and we were like, what's going on? So I had a physician, and she could take care of me today if I was to fall out on this stage. Love her. She's been primary care before a hospitalist for years, and she told me, Kelly, I am uncomfortable having this conversation. They are very uncomfortable. As a nurse on the back end, I used to always say, well, that's a doctor's conversation. Don't ask me as a nurse to have that conversation. Don't ask me as a case manager to have that conversation. That's a doctor's conversation. But also as a hospitalist, which I'm assuming that most of us use in this room, the hospitalist does not know the family doctor's plan of care. Have they ever had this conversation before? What do they know about their goals of life? Who's ever talked to them? So what we done was we took our palliative care team and our hospice team, and we brought them into to the other 2 facilities, and we started having talking points with the physician of how do you start that conversation with patients, especially if it's a dry run. You haven't seen this patient before, you haven't met this family before, you don't know how they're going to respond to this conversation, and so they felt so much better once our hospice company come in. And a lot of times they just need that little bit to start the conversation enough to where you actually can get hospice to help you finish it. They're more than willing to do that. They just want you to start that conversation so that way they don't walk in the room blind with it. Bringing back the discharge checklist, one of the things that we done as an organization once core measures for heart failure went away was we started taking some things out of the EMR. And the reason that we did that is we wanted to be sure that the nurses were not documenting something that really wasn't needed at this point. So we took all this stuff away, and we thought, we've done so good on this. Everybody's done great. We're not going to have a problem with this. Well, what we found was that the nurses really appreciated having that checklist to where once their patient had that discharge order, it wasn't a mad dash to get all of this stuff done. They wanted to be prepared and work on it, throughout the stay. So we've actually brought this back. Now, in our last meeting, we are going to try to make this back electronic again. But we brought this back in March, and so at this point, it's going to do 2 different things. It's going to give the manager on the floor a way to help us monitor that, the very basics of heart failure is being taken care of. Also, on the back end, for the patients that are readmitted, it's going to give our quality department an audit tool to be able to look back and say, what are some things we're doing really well? What are those best practices that are kind of set in stone in our organization? And then what are some things on the back end that we really need to work on? We've added some things. I know that's really blurry, but a lot of what it is medication. So are they on that beta blocker? Are they taking an ACE or an ARB? There's the new Entrestos out. Are we taking Entresto? Are we not giving an ACE and Entresto? Palliative care services. So we do want to embed this in the EMR, but right now we're just on paper. So this is a red zone flyer that we came up with, and you can see that there's not a logo on it. One of the things that we noticed in our community was that According to which area you went into, whether it be skilled nursing or home health, you received different education. The verbiage was different, and so as a community, we pulled together and we said, let's do one self-assessment tool and let's let everyone use it. And so we started going around once we narrowed it down and put all of our best practice in it. We went around and done education. What we found was that they were very, very thankful that we had already done all of this, and they were very appreciative to use the tool. So we made a couple of changes. No logo on here. They can add their logo if they want to, but at the same time, we know that once the patient gets through and moves through the different stages, that they're still using that same material. Ambulance companies, I wasn't sure how I would, with the feedback I would get from the ambulance companies. They love this. They know who your frequent flyers are. They know who your high utilizers are. Ambulance companies are almost all now electronic too. There's a lot of data you can learn from your ambulance companies. They have the time. They want the tools. They want the tools to be able to go over and talk to that patient that keeps calling them because they're short of breath, to be able to give them something that they know is good material that they can take and educate their patients. The cardiologist office wasn't sure how they would take that, but they actually loved it and thought that they could they even made some recommendations to add some things onto that bottom section, which I was very pleased with. We also wanted to change our verbiage and use dry weight. So one of the things that we noticed was that it's kind of like diabetics. A lot of diabetics don't know their A1C goal. A lot of times the patients don't know what their dry weight is. So if they don't know their dry weight, how are you going to know what their dry weight is? We discharge from the hospital and they're not completely down to their dry weight yet. A lot of times we will have them in there for 2 or 3 days and they'll be very close, and hemodynamically they'll be stable, but at the same time they still have more pounds that could go. So if we're leaving 5-10 pounds on them and then we're discharging them, it's not going to take but just a little bit more, and then they're back at that point where now all of that reserve's gone and they're going to be back in your emergency room again. So one of the things that we were telling them was to, keep it close by, whether it be on your refrigerator, close to your medicines, by your scales. They say that in order to do something and it be repetitive, you have to do it for 30 days. Well, we do not have 30 days. We don't want them to come back in 30 days. They need to learn how to assess themselves. So we start this in the hospital, and then they move to their post-acute agencies. They're going through the same scale. We have them walk up to that. They're, going down this scale. They're looking to see how, to learn how to do their assessments. So I was responsible one day for doing some follow-up phone calls, and I was talking to a patient, and about a week later she came back in, and so I went up to the floor and I asked her, I said, well, what happened? And she said, Miss Kelly, I did exactly what you told me to do. When I got to that red zone, I called 911. And I thought, I did not do a good job with her. Yeah, I did not do a good job. So reiterating that yellow zone, most definitely, letting them know and let their family know what their plan of action is once they reach to that. Okay, so this is kind of a little bit of a bread and butter for us, standardizing the home health and the skilled nursing. We have actually been having monthly meetings with our post-acute agencies for several years. We are in a very good position in our community. They're very open. They bring their RCAs. They talk about them. They really want to help us meet our goals, and we want to help them meet their goals. But what we learned from that conversation was that the home health companies and the skilled nursing facilities, they depend on all of their orders from us. And I pick on this one home health company, but we do the exact same thing at the hospital. I asked for their plans of care for heart failure one day, and it was an individual meeting, and they brought it in, and they were so proud, and they laid it on my desk, and they wanted to spend a whole hour with me talking about it, and it was 20 pages thick, and I said, how many times do you think your nurse at home is actually following this 20-page plan of care for heart failure? We do it in the hospital too. It's just overwhelming for that end user. And yet and still, even though they say, let's make sure you weigh the patient every day, let's make sure that you're checking SATs every day, if there's not an active order, they really can't do it. And so what we realized was that we needed to begin bring in best practice. We needed to make sure that we were standardizing some of that care in the post-acute setting, and we needed to recognize that they're now depending on us, and if we don't give them the orders that they need, they're never going to be able to take care of our patients the way that they want to and the way that we want them to. So I think I included both of these. Okay, the top section is for skilled nursing, but honestly, it's practically the same for skilled nursing and for home health. Number one, this is a high-risk patient. I am now giving you a high-risk patient, so there's a couple of things that you need to do. Home health, you do not have 48 hours to go and see this patient. You now need to see this patient within 24 hours. Skilled nursing facility, I need a doctor to lay eyes on this person within 3 days. That does not always happen unless you have an active order. Physical therapy, I need physical therapy 7 days a week. If you need an order to check SATs, here's your order to check SATs. Weigh your patients every day. I had a skilled nursing facility that was not weighing their heart failure patients every day. So now they have an order and they have to do it. And honestly, it wasn't on them. They wanted the orders. They wanted to be able to do it. They actually appreciated everything that we done. The bottom part is our medical director says that that's our bread and butter. We're still working out the kinks, but we've set up this diuretic sliding scale for patients that are both going home and home health. We want to do it for the patients that are going home, but we're afraid that without someone really close, that they wouldn't be able to work out the sliding scale appropriately. So we're kind of backtracking a little bit on the home setting, but. Not only are we giving them a diuretic, but we're giving them an order for the potassium as well, so that way we're not messing up with their electrolytes. They're only, in the order it says they're only allowed to do this 2 times. The second day, at that point, if they reassess, and they've already given the diuretic, that 3rd day, if they reassess and things are still abnormal, then at that point they need to call, because we want to make sure that we don't let that linger and that the cardiologist or the primary care doesn't realize what's going on. So we found that a local cardiologist around us was actually already doing this. So it was a way for us to kind of kick it off. And then we reached out to some of the other communities within the area and found that some of them were doing it for some of the diuretics, not for all. And then we added our own potassium base. So. The Health Information Exchange, this is fairly new for us. It's actually really exciting though. We have partnered with a third-party company called Patient Bridge, and one of the things that we've done is for Baptist, we're all connected to Cerner. It was very easy, since it was all Cerner, to get that information to flow into that HIE. But we have also challenged the home health and the skilled nursing facilities to go out and have access to that portal, so that way they can receive that information. And I believe in one of the earlier slides, someone was talking about implementing or getting a better H&P from the community physicians. Well, it's just exactly the same for the post-acute agencies. They want our discharge summaries, and sometimes it takes a while for us to get those on paper, so then they don't get them on the back end. So I'll kind of give you a couple examples. Kindred Home Health is pretty active in our community, and I tell everybody they're the walking billboard to this. They were saying the other day that there was a patient that they had seen, and that they had gotten to her house, and she had 3 bags of medications. She shouldn't have had 3 bags of medications, but everything that was expired she would not throw away. They had no idea. They had not received a discharge summary for us because the physician had not written it yet. So they were waiting on a discharge summary. They had a transition of care packet from us, so they had the red zones, they had her bag of medicines, they had our post-acute orders already, and they had her current lab work, they had her current vital signs, they had everything they needed to take care of this patient. 2 days after they admitted her, the patient called them and said, something's going on, something's not right. So the patient ended up going to the emergency room. I say today that the HIE turned this patient around. The nurse that was working for Kindred watched this patient, and because vital signs and lab work update real time, they were able to see immediately that this patient was dry. That's what had happened. She was dry, and so needed some fluids. She called the emergency room and said, we can take this patient back. Just wanted to let you know there are some post-acute services that are on board, and we're available to help if you need us. Administered some IV fluids in the emergency room, turned the patient around, and went back home with home health, resuming once she got there. So I definitely think that this HIE is going to save more and more readmissions. The post-acute agencies are seeing a lot of wins out of this, and we even now, as of March 6th, the VA, we can see the VA's information. So a lot of great news going on with that. Okay, so this is not in the online packet, but I did want to share to kind of see, let you guys see what was going on. I may have to take this off so you can see the numbers. So on the left-hand side, you can see we have traditional Medicare and then the all payers. So same thing. I mean, we need to monitor our traditional Medicare, but we want to affect this change for all payers. In the blue, you can see that's FY16. In the red, FY17. And in the green, that is our FY18 year to date. So we really started this project, I would say, probably August of last year when we really started digging in deep. And I mean, we've seen great results. I know that they downloaded not only the slides, but the documents themselves are actually on the website. So if anybody has any questions or comments, then you're welcome to ask me after this. Thank you.
I'm Kathy Hodge. I'm from Medical Center Barber. We're a very small rural hospital like most people here. For a long time we struggled with readmissions. We're still struggling a little bit. And length of stays. We were averaging probably about 15 to 20 readmissions a day, or a month, I'm sorry. And so we decided that we needed to do something. We needed to be in the community more. And find out for sure what was really going on with our patients, not just that they were non-compliant. So what I did was I created a readmission tool that got from one of our other meetings, and we participate with HEN. And so I adapted that readmission tool to fit our hospital. There was a lot of things on there that was just not appropriate for our hospital. So on the readmission tool, it's very simple. What I did for about 6 months is I would go and see every single readmission that we had. It was not very time consuming. We wear a lot of different hats in our hospital like everyone else does. But I would go and interview the patient, and I would ask why they came in, what brought them in. Obviously, I would already know before I went to see them when was the last time that they came to see us. What were they there the last time for? And then what did we do for them when they were there, when we discharged them. So I would ask them, did they go to their follow-up appointment? Did they get their medicines filled? I did this for about 6 months, and what I found was some of our patients were really not just non-compliant. We did have some that were, but what I found was that it was transportation issues. It was lack of money. We have a very large community of elderly in our community, and some of our readmissions were the same person coming in every month that we were seeing. And so we don't have a lot of resources in our city. We don't have public transportation. We have very limited ambulance services available for us. So we had to figure out a way to reach out to these. So I reached out to the local churches. We have a lot of those, and just asked, is there people who are available if we need someone to be taken to a doctor's appointment, if there's someone that we need to be taken home and just drop them off. Are you available to do that? And so they told me, yes, we may not be able to do it all the time, but we may be able to help you. I reached out to our pharmacists and our local, in our local community and asked, if I come to you with a prescription, can you give me the best rate on a medication for a patient, and we will pay for that, so that we can do the meds to beds. So they again said we may not be able to do that every time, but we can do it as periodically. So we just started this. We wanted to start it January the 1st of this year, and we had a little kink in some areas, and so we actually probably kicked this off about the middle of February. So we're still in the early stages of it. We have been able to help 4 people so far, and it's been a really great success with those, and we're still monitoring them. When the patient gets discharged, we do a 24-hour follow-up call. We do a 7-day follow-up call, and then we do a 30-day follow-up call. It's not just one person that does it. It may be myself that does it. It may be, we have one case manager. She may do it, or it may just be simply someone else that, a nurse, that may do that for us. It's kind of a team effort that we decided to do this with. We also decided, we used to do the daily huddles every day at 11 o'clock. We kind of fell off with that. People would come in, they'd sit down, you start talking about other things, your families, they would get very lengthy. And what we found was our physicians, and we use hospitalists, they felt that they were just not the meat that they needed at our meetings. So they got to where they just did not want to attend. So we reorganized it, and we created a daily huddle flow sheet. And what I did was, it's our clinical areas. It's our med-surg director, it's myself, it's infection control, and our social worker from our Geri Psych unit. We and our case manager, and also our CDI person, we got together and I said, what is it that you need from our physician? In 15 minutes, what do you need to know from that physician? And so I also got with our physicians and said, what is it that you need from us in 15 minutes? So I created this daily huddle sheet, and it has the different areas on it. We meet at 11 o'clock. We don't sit. We stand up. The physician comes in. They go through their list of patients. They tell us if the patient's going home, if the patient's staying for a few more days, why the patient's staying for a few more days. They tell us if there's any type of services that they feel that they need. I will tell you that within the first 2 weeks of doing this, we too were not using hospice like we should have. Actually, our physician and our case manager did not realize that it would actually help with our mortality rate if we used hospice. So within the first 2 weeks of just doing that, we were able to put 5 patients on hospice, whether it was inpatient hospice or at-home hospice. So that brought that out. We also have our CDI person that attends this, and this was an area that we're trying to improve on. And so she was able to give the physicians their queries at that time. If there were questions that she had about documentation or lack of documentation, and I do the appeals, so if I had questions, then I can say, I need you to do this peer-to-peer for our denial. And doing that, we were able to not interrupt the physicians throughout their day as much because we're doing it in this 15 minutes. Any outstanding cultures, infection control, she's there and she can identify if there's any type of outstanding cultures that's not been collected and why have they not been collected. We had a real big issue with sputums. They would still be ordered from a patient 5 days later. So now we have a protocol that it is done. We watch it every single day. If there's a culture that's not been done within 24 hours, and some within the shift, it's addressed right then. So there were a lot of things. We also address observation and MIP. If there's if a patient needs to be changed or anything like that. We have not yet, we've been doing it since about the middle of February, we have not went over 15 minutes yet. I mean, it's very, very quick. The people, the staff, they come in, they already have their sheet pre-filled out of what they need to address. If they don't have anything, they tell me. I keep the sheet in a binder and I follow up on it from day to day. We do this Monday through Friday. We're gonna eventually try to figure out how to do it on the weekends as well. But for now, we're doing this Monday through Friday. With the care transition, that's become our everyday language. We were having issues with our HCAHPS. We wanted to get our HCAHPS care transition score up. So what we did was we created a care transition bag. I went out and talked to a local screen printing company in our community because we did want to get more involvement with our community. And I told them, I said, I need a tote bag. I need it large enough that it will fit a floor scale in. But I need it to maybe put other things in it, but that would be the largest thing. I don't want anything fancy. I just want our name on it. I said, what's the best deal you can give me? I'm using you locally. You want us to shop locally. Tell me what you can do. So they did this bag. He gave me a price on it, and he didn't like the lettering on it, by the way. So he said next time he would do the lettering better. But these are our care transition bags, and what we did was I just went shopping. We identified what our top diagnosed patients of readmissions was, and that was CHF, hypertension, COPD, and diabetes. So what we did was we started with those, and for each one of those diagnoses, these are things that they may need. What we realized is we're telling a patient at discharge, you need to weigh yourself every day if you're a CHF patient, or this is your fluid restriction. They didn't have a way of weighing themselves at home, and they had no idea how much 1,500 milliliters was, or 2,000. So what we decided to do was to actually put those tools in their hand. So now, based on their diagnosis, they will receive maybe not all of this, but whatever fits to them. It may be that it's the pill box. They need a way of organizing their medication for their elderly. We have the blood pressure cuff and the floor scale, and then we also have the thermos that they can actually see this is how much you can have. These tools, if they get them, they're actually start using them while they're in the hospital. We start our discharge on a mission. All of our education is started at admission based on what they're there for. We have a care transition folder, and all their information goes into that folder. We also have a very low literacy rate in our community, so every bit of our material is based on a very low education level to where they can understand it. So we're giving it to them for CHF, we actually take the scale to them and we have them weigh themselves on that scale. So that way they know how to work it, they know how to read it. So when they go home, when we do our follow-up calls, they know what we're asking for. And we also have the pamphlets, the booklets. I'm cheap. I try to get what I can get for $1. So I make these booklets. I just do it online on my computer. We got together I get with the employee education. She and I get together as to what needs to be in it for that diagnosis, and we put it together. We print it, we staple it, and that's what we give them. I don't order it because that's just another cost. If you put everything in this bag and they were to get everything, it's about $40 a bag. I'm very proud of that. This is my passion. This is my baby. With the 4 people that we've been able to help, 2 of them were going to be long length of stays, as in the past. We provided them with Lovenox to where they only had to stay in the hospital for 3 days rather versus 7, 10, 15 days just because they were getting a transition. We bought the Lovenox for them and they were able to go home. One, because they didn't qualify for home health, or they did not have the money to pay for the medication. One of the others, we were able to, which is probably our biggest one that we're very proud of. We've been dealing with him since 2011. I've been at the hospital for 10 years and I'm the abstractor, and I promise you when I abstract him I can put his name, his birthday, his social security number, everything. I don't even have to look at it anymore. That's how many times he comes in. But from 2011 to 2017, and we just got these numbers pulled, he has no insurance, he's unemployed, he's in his 30s, and his hospital bill alone with just us was $260,000. We started this care transition with him in February. Everybody always said he was very non-compliant. He was. He would see me come and he'd like, I don't want to talk to you, Miss Kathy. You know, I know why you're here. But he has visited our hospital twice this year, and that was in February. That's when we started this care transition with him. We got him hooked up with Spectre Care, and through Spectre Care, he could see the psych doctor through there, and they would actually, through a program they have, would provide him with his psych meds as long as he could pay the $32.50 physician fee. We paid that. So he got his psych meds. If he did not have a primary care physician, so we hooked him up with our clinic, and if he saw a primary care physician, Spectre Care would also pay for through a program, would pay for his insulin because he was a very bad diabetic. So we paid his physician bill, which it's around $120 self-pay. It's not been finalized yet. So basically for around $200, we just kept a patient out of the hospital. And knock on wood, as of yesterday, he has not been a readmission to our hospital. He has actually called our case manager and said, Miss Missy, did you make my appointment for me? If you know this man, he would never, in all the years that I've been there, would never do that. But just by reaching out to him and showing him that we were trying to help him, if he just picked up and did a little bit on his own, we have been able to do that. So that was how we got, and we're trying to get some other administration, the big dogs with all the money, to give us some more money, is by showing them $260,000 that was costing our hospital that we'll never see that money. That's actually, some of that's been turned over to collections versus paying $200 for this patient that's actually kept them out. He will see the psych doctor every 3 months, and we may follow him for a few months just to get him on track, but he's showing improvement. So those are just a few little ones that we've been able to do so far. We hope that in the future we're going to try to set up meetings with our community, with our home health, with our hospices, and try to get a more community involvement of what can we do for you, but you can do for us, that we can help each other meet your goals. So, thank you.
Okay, I realize we're running a little tight on time. What I would like to suggest is if you have questions, let me let you just catch them during the lunch. We're going to go ahead and start our lunch break. We're on a tight schedule to get started back in this room with a session at 1 o'clock. During the lunchtime, there's also the MedMind meeting that will occur next door in the bronze room. Boxes for those lunches will be in that room, as I understand it.